Hello, I'm Victor Zhao, the president of the National Academy of Medicine, and of course, on behalf of Mark McClellan, director of the Duke-Margolis Institute, and who'll be speaking very shortly, I want to welcome you to today's webinar. It's titled Collaborative Action for America's Health, Short and Long-Term Strategies Across Public Health, Health System, and Social Services. Well, you can imagine how important this topic is. And what's exciting is that this program is a joint effort between National Academy of Medicine and Duke-Margolis Policy Institute, and also hosted in collaboration with CDC. So I'm very pleased to welcome an array of federal officials and leading experts from across healthcare and public health who have worked with us to develop the strategy recommendation you'll be hearing today. Later on. I think we all recognize, of course, for all of you who are in the healthcare space and beyond, the health challenges facing the United States in the 21st century require a reinvigorated, feasible approach to public and population health. This approach must leverage traditional public health institutions working closely alongside with health systems and social services. Certainly, both Mark and I and CDC has espoused this for quite a while. But now to do this, will require better leveraging of digital data systems, biomedical innovations, as well as policy and payment reforms designed to enhance community-specific capabilities through public-private collaboration. So enhanced public-private partnership will in turn enable better prediction and response to public health challenges, restore public trust and confidence, which is very much needed, and to help us build increasing resilience and sustainable health care and public health capabilities. I think it's a tall order, but it can be done, and I'm very excited about today's webinar. Can I have the next slide, please? So today, we'll hear from a variety of speakers on these topics, including the CDC Director Mandy Cohen and CMS Principal Deputy Administrator John Blum. After remarks from our federal leaders, we turn to our panel discussions. First, we'll present specific recommendations on two major threats to public health in the United States: the burden of respiratory infection. Well, don't we know it? My family is now all coming down with respiratory infection in a big way. And because this is the season. And also the consequence, another big crisis, opioid and substance use disorder. These things are what we're going to use as these two cases as examples of what can be done. And finally, we'll close with a high-level panel discussion on the importance of public-private collaboration in US public health and healthcare spheres. May I have the next slide, please? So with all that, we just got great input from a fantastic set of speakers today, as well as a planning group who have contributed their time and energy to this very important initiative. I'd like to thank each and every one of them for being here today. You know, our collective goal, both as part of this webinar discussion and part of a much broader ongoing initiative that we and Duke-Margolis is working on, is to identify programs, interventions, and policy levers that could be scaled both locally and nationally within the next 18 months to strengthen the nation's response to a large range of population priorities, not just these two. But as I said in my closing remarks, this is actually a long-term commitment from both of us that we want to continue working on this to create a long-term strategy to help to improve the health of the nation. So thank you again, welcome. I look forward to discussion of this topic. And so with that, I'd like to turn over to my partner from Duke-Margolis, Dr. Mark McClellan, to expand on the major themes that we've identified in our work thus far. Mark, over to you.
Victor, thanks very much for introducing today's session, and I'd like to add my welcome to this group on behalf of our team at Duke-Margolis and our collaborators, the excellent planning group that put a lot of time and effort and thought into coming up with short-term steps that can be undertaken now, that can start now at a challenging time for public health and for finding effective pathways forward. As Victor noted, we have published along with this event today an initial issue brief that focuses on some of these near-term imperatives for collective path forward on improving the nation's health. These recommendations combine steps that are feasible, we think, for the federal government agencies working together to take now to advance population health and make it easier at the local, state, and national level to make progress on these important public health challenges. So these feasible steps are very much focusing on bringing together the healthcare, public health, and community level activities, which are increasingly able to work together thanks to progress in early diagnostics and medical interventions, thanks to progress in shared data systems and the ability to have better situational awareness to focus efforts, and to now growing experience on how community activities can come together, led by healthcare, public health, community leaders, and community members to address these important collective challenges. So I think on the next slide, we describe these two areas where we see many of these short-term opportunities to improving population health, and that you'll hear more about in our panel discussions today. First area, as Victor mentioned, is strengthening protections for individuals and communities from the complications and disruptions of respiratory infections. Some of those are minor and inconvenient, but in people who are at risk, and if happening at a large scale, can really be disruptive, not only for the health of individuals, but for the ability of local health systems and communities to function as effectively. And then second, preventing overdose deaths and other complications of opioid use disorder. We've seen OUD deaths rise in recent years, plateau more in the last year or two, but still at a very high level, despite the availability of better treatments than ever before, better alternatives, prevention steps than ever before, and better ways to respond to emergencies involving overdoses when they occur. We chose these particular areas on our planning group because it seemed like there are these opportunities for near-term progress. And that's what we're going to talk about more today. But these are representative areas where further foundational collaboration across healthcare, public health, and community efforts can advance progress on a range of public health threats and population health threats facing the nation. If you go on to the next slide, the issue brief and our forthcoming longer paper describes these underlying cross-cutting foundational steps to enable short-term progress in a range of areas of public health challenges. One of these areas involves improving the use of electronic data to inform awareness about these threats at a local level, and through that enable more timely and effective action by healthcare systems that are often stretched, by community organizations, businesses to respond to these threats. A second area is leveraging healthcare payment and delivery reforms to increase healthcare capabilities, to improve population health, to help head off some of those costly downstream complications that can add to hospital burdens and add to medical costs in these areas as well. A third area involves strengthening effective and accountable community health collaborations across public health, health systems, social services, and community organizations. You'll hear today from a number of our participants who are actively involved in some of these community-based efforts that would benefit from the other steps that we've described, and that are being supported by more collaborative efforts at the federal level to advance local capabilities and support them. And then fourth, helping trusted healthcare and community organizations provide timely and accurate information on these public health activities and the current state of threats in their community and things that people in the community can do about them. Practical information that individuals, families, businesses, and community organizations can use to make informed decisions about their health. Again, federal supports for these local activities that are already underway and that we think can be strengthened in the short term. So we're looking forward to discussions about all these topics today. We're looking forward to the more complete paper that will be released by the National Academy of Medicine in several weeks. And we're looking forward to more discussion with all of you on making short-term progress and improving America's health. And with that, I'd like to turn back to Victor to introduce our first speaker.
Well, Mark, I think that you've given us a taste of what's to come, and I'm very excited about this. First of all, I think the participation of the entire planning group, which I showed earlier, is so important to get to where we are. But I think to call out the federal leaders from CDC, CMS, and others who all want to work together to make it happen is what we want to feature now in the next session. And of course, John Blum, that you'll hear later, but I get to introduce Mandy Cohen. And what a pleasure, because, as you know, she's director of the U.S. Center for Disease Control Prevention, but I've known Mandy for a while, first as an internal medicine physician at the Mass General, and of course, then the North Carolina Department of Health and Human Services, where I still reside as a Duke faculty, even though I'm on leave at National Academy. And she's done some amazing work during COVID crisis, focused on equity, data accountability, and transparent communication. But I remember when I left North Carolina, it was just at the time where we were debating that we should expand Medicaid. And legislature says, no, we don't trust the current administration. We will take on this cost. Maybe we're going to have to end up taking them on. But Mandy has been able to, through her tireless effort as the director of DHHS, to work with the legislation, with the public, to expand the Medicaid. And I'm happy that we've done it. And so many people are going to benefit from it. The other thing is, she's actually leveraged Medicaid to focus on whole person health, but launching the country's first statewide coordination platform. With our shared North Carolina background, I'm so proud to call him Mandy, not only a member of National Academy of Medicine, but also my friend. So let's roll the video on the remarks.
Hi, everyone. Good afternoon. It's great to be here with you today talking about how we can collaborate to protect America's health. We've learned so much over the last 4 years that we must embed into our work going forward. As you all know, we face major challenges at our doorstep, everything from infectious diseases like COVID and malaria, Mpox and Ebola, to ongoing challenges of chronic diseases and a behavioral health crisis. But the good news is we are also in an unprecedented moment of scientific breakthroughs, powerful detection and diagnostic innovations, and artificial intelligence advancements that are game changers. And we have more tools than ever before to carry out the mission to protect health. More vaccines, more data, greater awareness about the need for and contribution of public health and healthcare. The question facing all of us right now is how can we work together, collaboratively, to meet this moment and protect health? As we chart a path forward, we need to build an integrated system that protects the public's health. And this goes well beyond the reach of CDC and traditional public health. The best paths to address health threats are evolving. So this system will require connection and collaboration across healthcare, across public health, government, private sector, social services, academia, education, and others, both domestically and globally. No one agency and no one entity can do this alone. We appreciate the recommendations outlined in this issue brief that will help federal agencies work together with state and local healthcare, public health, and communities to make progress in the near and longer term. Better collaboration requires ways to exchange and use data between healthcare and public health, shared priorities and investments, and clear roles and responsibilities so that we can share accountability in protecting health. These partnerships and collaborations must focus on and demonstrate value for their communities, including reducing the burden on an already stretched healthcare providing system, and prioritize and focus on top health concerns for communities that we can all act on. Two areas of recommendation in this brief, seasonal respiratory viruses and preventing overdoses, are priorities for the CDC right now, and concrete action steps now is particularly urgent for these two areas. At CDC, we're protecting health and improving lives every day and looking at how else we can use our current expertise and authorities and investments to protect against fall and winter respiratory viruses and prevent overdoses. We're making major investments in federal, state, and local data infrastructure. We're using new tools like wastewater detection, and we're collaborating with partners like the AMA and the American Academy of Pediatrics and CMS to ensure payment reflects the work clinicians are doing each day to protect the health of their communities. As you engage in the panels and discussion today, I appreciate each of us thinking about what actions we can take now, and how each of us can be clear in our roles and how we work together to protect health and improve lives. We need an integrated effort to keep this country protected and healthy. It's a team sport, and I'm grateful to have each of you on our team. Thank you for your continued partnership and collaboration. I look forward to working together.
Well, I'm gonna have to give a round of applause, even though she's not here to hear it. But I do say that thank you, Mandy, for your leadership and your partnership with all of us. First of all, you've articulated where we need to be very clearly, and this is what Mark and I and the whole group is trying to do. We're there to support you and to enable this collaboration across public health, healthcare system, and social services. With that, I'd like to turn over to Mark to introduce our next speaker.
Great. Thanks very much, Victor. And add my thanks to Andy Cohen and the CDC team has been collaborating on this effort. This is a very busy agency right now, especially in the midst of respiratory season and so many other public health challenges. Their commitment to finding new ways to bring their programs together and work with other agencies on shared goals has been an important contributor to the recommendations that we're putting forward today. And now I'd like to turn to another very important leader from a federal agency that has a lot to do with the nation's public health and population health, and that's John Blum, who's the Principal Deputy Administrator and Chief Operating Officer of the Centers for Medicare and Medicaid. And just to put things in perspective for those of you who may not have spent so much time with CMS as John does now, as I have in the past, this is the largest healthcare payment agency in the world. And John, back when I had the privilege of being administrator, I remember, I think it was my first talk with our CMS staff, and I started out by saying, you all are part of the nation's largest public health agency. And aside from getting corrected by a couple of my advisors then say, hey, Mark, you're at this is the agency's under the Social Security Act, not the Public Health Act. The staff really did get that how we pay for medical services is increasingly important for the well-being and health of people across the country. And I know one of your priorities at CMS, which is now much larger and potentially more influential than when I was there, is around these partnerships with other federal agencies, including the public health agencies, and the private sector to make it easier to make progress on the kinds of issues that we've talked about today. Could you maybe just talk a little bit about what you see as the opportunities and the challenges in this space related to what we're talking about today?
Yeah, thanks, Mark, and it's really great to be here. I want to really echo Mandy Cohen's comments to say thank you for the work to the whole collective team. This is going to be valuable. This is going to be helpful, and to really give us much clearer direction for the future. But one thing that we're doing here at CMS is really looking back to the past 3.5, 4 years since the pandemic started. And I think one of the key lessons for us, and I think following Mark, your work here here at CMS, is that CMS can no longer afford or has the luxury to be just the payment agency. And all the things that we had to worry about during the pandemic, for how we keep nursing homes open, for how we protect workers, keep the healthcare system working, meant that CMS had to form new partnerships, that we had to really build even closer connections to how care is being provided. Needed to form better connections to our CDC partners, to the FDA, and so that's been one core lesson for us, and that will continue. And so, how CMS sees itself as being part of the fabric of the public health response, the health system support. I think the silver lining from the past 4 years is, for us, a much stronger commitment to the vision that you set out during your time here at CMS. Second thing for us is we have always thought about payment reform as being mostly focused around cost savings. And I think it was the ACA brought in more direction to CMS to think about ways for us to change payment to improve health. One of the primary factors really was thinking about cost savings. And now with this post-pandemic world that we have to think about, that I think one of the core purposes for us to think about how to pay better, for how to support healthcare systems better, for how to support the healthcare redesign really more forcefully, is to have the framework be that part of the mission, part of the purpose is to build more resilient healthcare systems. And so the things that we think about and worry about is the populations that CMS serves were those that were most harmed by the pandemic. CMS is the largest payer of nursing home services, for example, and those that reside within nursing homes were some of the worst, had some of the worst outcomes, highest death rates. For example, the ESRD population, those that are covered by that need daily dialysis care, they too had some of the worst challenges during the past 4 years. That's precisely the population that CMS needs to consider when we're thinking about how to pay wiser, how to pay better, and how to support healthcare transformation. So the silver lining for us during the past 4 years that was horrible, that was hard for us to even think about, but that silver lining is a much stronger commitment for CMS to be part of this more global fabric, and for us to reimagine what it means to think about payment reform, payment design, to help support, to build much more resilient healthcare systems.
Yeah, John, thanks for those initial comments. And as you said, while being a payment agency, there are, it seems like, increasing opportunities to make a difference in public health and population health. And certainly your efforts around advancing so-called value-based care, including the CMS goal of moving away from paying fee-for-service, instead paying for healthcare organizations that can help people meet their overall needs, including facing some of these public health risks, is an important priority for the agency. But you are dealing with a healthcare system that has been pretty stressed over the last few years, and that I know is very much interested in these goals of advancing population health, but also worries about things like administrative burdens and stretched staff and other obstacles to really focusing on moving forward on these kinds of population health goals. Can you talk a little bit more about some of the steps that you're taking to engage the healthcare community along with these other federal agencies around these shared goals?
Sure. There's so much there to cover, but really a vital question for us. Let me just talk through some examples just to make the work more concrete. We are working in close partnership with the CDC to rethink, reimagine for how we collect vital information from hospitals, nursing homes, for example, to really track, trace, and better monitor what's happening on the ground. And so we had to put in place a very rapid response with new rules, new regulations that were just new for the agency. We're going to reimagine that so that it's easy, that it's simple, and that the system can flex when we have much more urgent need. And so we recognize that all the things that we did together to collect information, monitor the healthcare system, that takes a lot of staff, a lot of time. And so folks here should expect that CMS with CDC together will be moving forward with a much more simpler system in the future. So that's one example. For participating within the CMS payment models, the ACOs, for example, that our vision is that it is far easier, far simpler, far more intuitive to participate within one of our models. And so we recognize that many of the things that we have tested in the past bring in a lot of complexity, which then deter participation. So our team is thinking hard for how we make participation, the design, the technical requirements to be simple, to be intuitive, and to really garner much more participation. The third thing that we're doing is taking a very close look at all of the requirements and all the challenges that we have in our healthcare system, and to have different requirements in Medicare and Medicaid, and through the private insurance market, and to make it again more consistent, more simple, more intuitive. One important step that we took over the past couple of months is to put in place new requirements for how we do prior authorization, to have consistent rules, consistent interface, and the healthcare industry should expect more of that from CMS, demand more of that simplicity from CMS, because we recognize the healthcare workforce that we have in place today is probably not going to grow more substantially in the future. Therefore, we have to make sure that we are giving back time, back to physicians, back to clinicians, so they can spend more time with their patients and less time following CMS rules.
Thanks, John. And could you talk a little bit more about how that approach of trying to reduce administrative burden extends to any of this collaborative work with the CDC and potentially other federal agencies? We were just talking about prior authorization rules now building off the electronic medical record standards, which CMS oversees, with the goal of making it simpler and easier to exchange information, and I guess also add to that to use it to improve patient care, to share data to help prevent these complications, as you're saying, for people in nursing homes, identify those who are at risk and might need more help to enable that more population-focused healthcare. So uniform standards that are adopted and that apply widely certainly would seem like would help with that in healthcare, as people have time to adjust and adopt to those standards, and electronic record manufacturers in particular do in health plans. One of the big complaints that we heard during a lot during the pandemic was not that people didn't want to share data about case surges and new variants, but that each state and local public health system had different data capabilities and requirements for reporting on that information, which made it kind of harder to submit the data and certainly harder to get back timely information that those healthcare organizations could use, putting it all together to see where the risks were. Does that same approach that you've talked about for CMS's strategy around reducing the burden of moving towards more of a population health system, how does that apply to the work that you're doing with CDC and other public health agencies?
Yeah, it's a great question. I think the way that I think about it is we collectively in the federal government require many different ways for entities to report data for different purposes. Some is public health, some is the healthcare financing rules requirements that we set within CMS. But where we're driving for is the vision to be one simple interface, one common interface, more of the information being collected, not through separate data reporting requirements, but through the EMR, common standards, common processes, and to align Medicare, Medicaid, private insurance much more in the same direction. It requires a lot of technical hard work. It requires us to really kind of redesign how these processes work. But I can assure folks who are bringing the burden concerns forward, which is hugely important, that our vision for the future is that the interactions, the reporting, the interface really is simpler, really starts with the EMR and has common standards. But this is a shared goal, not just for CMS, but all of the partners that we work with within the federal government. And I hope that the folks here hold CMS accountable to pushing forward that vision.
John, thank you so much for joining us this afternoon. You've got a very
thank you for all the work.
schedule.
Yes, I mean, thank you. Yeah,
we really appreciate the collaboration with this effort, and would say that some of the recommendations we'll turn to now build on exactly that goal of having a more standard interface based off of the increasing electronic record capabilities, and then making sure that turns into specific data requests that not only help the public health agencies, but help healthcare organizations be aware of and respond to the public health threats they're facing. So thank you so much for being with us today, and we look forward to the CMS's continued leadership on these issues, along with everything else you have going on.
Great. Thank you, Mark. Thank you, Victor.
And thank you, John. Thank you very much.
And I would like to build on Administrator Blum's comments in our next session, where we're going to have kind of a fireside discussion, I think, between Carlos Del Rio and me about some of the recommendations in that issue brief issued today, the more complete recommendations that are forthcoming next month, related to reducing the burden of respiratory infections. For those of you who don't have the pleasure of getting good advice and perspectives from Dr. Del Rio over the course of the pandemic, Carlos, I don't know very many people who are on the news more than you were, trying to provide clear and accurate guidance about what we know, what we don't, and what to do. Carlos is currently the interim dean of the Emory School of Medicine, has taken some important steps there to integrate approaches at the School of Medicine with public health strategies, very much in line with the overall goals of this effort. And Carlos, let me just turn to you for a kind of an open-ended chance to start this discussion on some of the leading opportunities and how we can overcome the challenges and in achieving the goals of better collaborative action for public health, particularly focusing on reducing the burden of respiratory infections.
Well, thank you, Mark. Thank you for the invitation to speak today. as you know, my history and my expertise in research comes from the world of HIV. So the HIV look at things, and HIV has been one of the greatest pandemic. And I think the success that we've had locally and globally in HIV is that, typically public health is at one side and clinical care is in the other. And what we've been able to do in HIV locally to some extent, but more importantly, globally, we've been able to bring clinical care and public health together, working in a collaborative way. For example, when you think about, a lot of the things that have happened globally, it has been in response to public health. It has been in response to public health data. It has been data informed. It has been driven, actions have been driven by having data that you can act upon. So I think that the first lesson is when we're looking at a pandemic, and it could be HIV, it could be TB, it could be COVID, it could be influenza, but it could also just be the regular approach to any infectious disease in which the clinical and public health infrastructure are involved. We have to find better ways that the silos communicate and talk to each other. We need to have ways in which the information generated in healthcare is shared with public health. The information from public health is shared back with the clinical care. So at the end of the day, this integration, this collaboration, this data sharing, to use data to inform actions, in my mind, is a critical first step. Then you obviously have to bring people together to the table, right? There has to be a win for everybody. There has to be a win for the individual, for the population, because health systems are typically focused on the individual. Public health is typically focused on the population. But you work with the population starting with each individual. You create vaccinations by vaccinating each and every person. You don't vaccinate populations, you vaccinate individuals. So I think there's a lot of that can be done by realizing that public health, population health, is nothing but individual health at scale. It's taking this to a higher level and thinking about how do we take those steps and bring them to where we need to. So I think there's a lot of opportunities, and I think what we can say out of COVID is that a lot of people in healthcare that typically don't think public health all of a sudden started saying, well, maybe we need to talk to public health. It's important for us to communicate with public health. Public health has a lot of the answers. Public health is how we're going to get our testing. It's how we're going to get, our vaccines. It's how we get access to treatments. So at the end of the day, that collaboration, that cooperation, that data-driven collaboration and information gathering, I think is critically for us to function in a more effective way.
So let me dive a little bit deeper into some of the themes that you brought up around practical next steps to support better collaboration. And let's start with data, especially just on situational awareness in a community. We have, so I think we're showing some of these 4 areas here, and would encourage everyone who's with us, if you haven't downloaded the paper already, it's a pretty quick and easy read. So please do take a look. This first recommendation around data sharing on respiratory infections. So you heard John Blum from CMS say that he thinks there's some opportunities to both reduce the burden on healthcare providers and get more actionable data quickly using the foundations of electronic interoperability standards that we have in place now and that could be improved over time. As you know, one of our recommendations is a focused effort to do that for reporting that healthcare organizations often have to do anyway, certainly had to do in the COVID pandemic around COVID cases hitting the emergency room or admissions to the hospital or ICU beds. Right now, or historically, those data might get reported to CMS, might also have to be provided to public health organizations, but those organizations historically haven't had those same data systems in place. Could you say a little bit more? I mean, maybe drawing on your points about HIV, situational awareness, about how to make this a win-win in the near term, both for healthcare organizations and public health agencies. Otherwise, I think some healthcare organizations may view this as, well, this could be just more requirements coming from CMS about reporting standards when I'm busy dealing with other urgent administrative issues too. How does this reduce administrative burdens and help healthcare organizations do their job more effectively?
Well, I think there's several components. First of all, while I agree that data sharing with CMS and others is important, the current system right now is that data is shared in not in a timely way. So by the time you get the information, it's not going to help you. It's looking at the past, not looking at the future. So I think we need real-time data sharing. I want to know what happened yesterday. This reminds me of, if I get a CBC on a patient and I don't get the result, within an hour, but I get it a month later. A month later to find out that somebody had anemia is not going to help me that much. That person may already be dead or may already be better. So we need real-time data sharing. And, unfortunately, now we have in most healthcare systems, thanks to a lot of effort that was done during the Obama administration, most healthcare systems now have electronic medical records, but those electronic medical records keep the information internally and rarely share that information. There's beginning to be some sharing, but I think we need active agreements that allow that sharing of de-identified data, that information. I want to know that yesterday our emergency room had a spike in number of tests requested for respiratory viruses. So I can make actions today. I don't need that to be something that happened 6 months ago, because then it's really hard to act. So I think, we need to make real-time data sharing, and we need to make it easy. We don't need to make it a burden on the healthcare system. We need to make it something that essentially happens automatically, no different than, reporting the CBC or the chemistry results is not a burden for the laboratory. Automatically, it interacts with their system in the lab, interacts with the electronic medical records and puts the information there. They don't manually do that. They don't sit down one day and say, okay, let's dump all this data that we now have into the EMR. So I think we need those rapid interactions that allow for that data in action that takes place right away. The second is we need to provide the kind of either recognition or incentives for those healthcare systems that are collaborating with public health in that respect. I mean, it'd be really nice to be able to say healthcare system X is a 5-star public health collaborator, has a recognition as a place that actually is doing something to improve that communication in public health. And that public health can say, well, data we have from our healthcare system partners is showing us this, that, and the other. We need to align the financial incentives, and we need to align kind of standardized, case reporting data that, again, nowadays, a lot of those things happen automatically. You can just make them so easy, but it needs to have the infrastructure. There needs to be the investment to actually create those data flows that actually fall into the right places. And then we need to have public health create those analyses, analyze that data, look at that data, and feed it back to the healthcare system. I mean, there could be a way of saying, look, we looked at all your data, and whenever you test for respiratory viruses, people under the age of 25, only 1 in 100 came back positive. But when you test people over the age of 60, it was 1 in 10. I think that data was something that the healthcare system would like to know and will help them make better decisions into how to target, how to better utilize their resources. I think that the ability to then the healthcare system use the data coming from public health in an effective way is something that we need to look at. And how can healthcare systems benefit from getting data that says, the population you're serving, only, 60% of the population is vaccinated against COVID. We encourage you to look at X, Y, or Z individual as somebody who can really benefit from additional vaccination for COVID, influenza, respiratory virus, RSV. We don't have, for example, our testing databases throughout COVID, our testing databases and our vaccine databases were not communicated. So we didn't know who was getting infected. Have they received full doses, 1 dose, 2 doses? People could do it locally, but we could not do it as a nation. So again, there's a lot of efforts that we need to use. We have a lot of data. We're just not simply using it appropriately.
Yeah, and on that point, as you know, the recommendations included steps for public health agencies funded by the CDC to use their data infrastructure support to get alignment with those same interoperable data standards that are now required for healthcare organizations, so that both public health and healthcare could have more complete timely, actionable data. You know, as you pointed out today, for all of these respiratory threats, there are rapid laboratory tests available. There are treatments available, vaccines available, and having shared situational awareness at a lower cost for those data would really help. Victor, were you going to add something, or?
No.
Okay, just to, I know we're running short on time, but I did want to get to a couple of other related points quickly, Carlos. You talked and John Blum talked about steps towards paying more in our Medicare programs, Medicaid, commercial programs for keeping people well, making sure they're aware of and getting timely access to vaccines and treatments especially if they're at high risk. Medicare has implemented some value-based payment reforms and some performance measures in this area that are intended to support those kinds of stronger payment alignment and sustainability for detecting and preventing and containing respiratory illness. You mentioned that payment was important. Maybe you could say a little bit more about how additional reform steps in this direction, steps that CMS is taking anyway, but maybe could accelerate, could make a difference for containing respiratory outbreaks.
Well, you know, again, healthcare systems have a role to play in impacting populations, but we need to be proactive and not reactive, right? So, you know, if Medicare said, for example, that there'll be an additional incentive if your over 65 population has greater than 80% coverage on influenza vaccination, trust me, healthcare systems will do whatever they need to do to ensure that in their clinics, people are vaccinated. They will call individuals, they will say, come, we'll give you a vaccine. So I think there needs to be the incentive of what's in it for me? How do I save money? You know, unfortunately nowadays, Mark, as you know, our payment system, you know, if I give somebody an influenza vaccine, I get, you know, a couple dollars. But if that person doesn't get a vaccine, gets influenza, and ends up in the ICU, a healthcare system makes a ton of money. So the incentives are done the wrong way. The incentives are done for me to, you know, I'll be very happy when somebody shows up in my ICU and gets admitted and gets ECMO and gets all these expensive things, because that means a lot of money. But if I prevented that infection, I don't get that additional payment. So how can we change the incentives in such a way that the incentive is not to take care of sick individuals, but actually to prevent people from getting sick, to actually improve population health? That's where we need to change the incentives. And, you know, you and I have been hearing a lot for many years that we're changing to this approach, but we really haven't been there. We're not there yet. And we're going to have to, at some point in time, do this and take the plunge and say, look, you're going to get paid less for failure than for success. And the moment that happens, then we're going to go for success. We're going to go for prevention. We're going to go for better control of hemoglobin A1C as something that pays better than doing an amputation or putting somebody on dialysis.
And we've seen a lot of healthcare organizations moving in this direction. Time for some more concerted action. Carlos, I want to thank you for taking the time on this report. Thank you for this thoughtful discussion around some of these action steps that are possible now to make progress on respiratory infections. Victor, I'd like to turn back to you for some discussion about our second set of recommendations on these same themes, focusing on OUD hospitalizations and deaths.
Thank you, Mark and Carlos. Terrific conversation. I think all the points that you hitting home, and you're spot on, and let's try to make it happen. So let's turn to the next one, another big issue, a crisis, which is opioid and substance use disorder, and particularly overdose. And I'm very pleased to be joined by my colleagues, Ann Zink and Fred Surais. Ann Zink, there she is the Chief Medical Officer for the Alaska Department of Health, Division of Public Health, a position she's held since 2019. And she's done just a fabulous job. It's great to work with her as a member of the planning group. And she's had 14 years of experience in emergency medicine, joined Alaska Department of Health from Mat-Su Regional Medical Center, where she served as Emergency Department Medical Director. Fred Surais has been President and CEO of the Parkland Health System since 2014. And prior to arrival at Parkland, he served as Associate Dean for Clinical Affairs at, let me get it right, Louisiana State University. And before that, as Vice President of Health Affairs and Medical Education of Louisiana State University System. So thank you for joining us, Fred and so we have about 20 minutes, maybe a little less, to get through this. And so I have a whole bunch of things I'll ask you. First of all, let me ask you this question. Why is it such a crucial issue to address? And where might we see the highest likelihood of long-term success? And second, what do we need to focus on to improve data analysis collection in this issue? And well, let me stop here because I've got 4 questions for you, but I'll do it one at a time. And Fred, let me ask the first question. Why is this area so important?
Yeah, Victor, I so appreciate the opportunity to be here. And I think that much of the team has already spoken to some of the importance of thinking about public health and healthcare coming together. I personally really love, and I am very grateful for Duke focusing on respiratory illnesses as well as substance use, because I think they give us case examples, use case examples for us to dive into and to say, let's take this one problem, let's dive into it and use it as a canary in the coal mine to better understand how does healthcare and public health work together to improve population health, to save money and improve the health and well-being of all Americans. And so I think substance use disorder is a great example. It has to do with how public health is trying to stand in. We know that 80% of naloxone is sent out by local and state health departments, but it's a medication that the healthcare system could pay for if we figure out how to do that a little bit better within the system. We see the ways that loneliness, isolation, mental health, schools, workforce all play a role in substance use, and also has a really great and really important role to work with law enforcement to think about interdiction, trying to make sure that people don't have access to illicit drugs like fentanyl, where one drug can kill and it can be in a poisoning in a short bit of time. So I think that if you really look at the opioid use disorder, is a great intersection between the social health-related needs outside the healthcare system, and public health. And by focusing on it in these 4 topics that Duke has really laid out, you can find meaningful solutions that will not only make a difference for opioid use disorder, but for the whole system as a whole that can be applicable to other challenges as well.
Yeah, thank you. I think it's so important. And you emphasize the whole issue of multi-stakeholder collaborations. So Fred, what do you think? What are examples you hope for long-term success or near-term success? Because we want to see the next 18 months that we're able to implement some of these changes.
Yeah, I think, Victor, thanks for the invitation to be here as well. And, just to add on to what Ann commented on, opioid use is a great test case or a case to work on because it's such a huge societal problem, right? And it crosses so many different areas within healthcare and other social entities. And that's, when we start talking about data sharing, we have to think about going beyond healthcare and public health as well. So it's an enormous problem. You've got fentanyl that people may not even know that they're taking when they're overdosing on this substance. And so the interventions are going to have to be across not only healthcare and hospital systems, but EMS, police, jails, public health agencies, pharmacies, schools. So the list of sites and organizations that are impacted, people with opioid use disorder that they interact with, is so broad. And so it's a critical public health issue, has multiple stakeholders. So it's a logical area for us to focus an initiative like this on. And I know we're going to talk about data, and I think, some of the data sharing opportunities, you will see some opportunities for short-term wins, identifying, sharing data on where some of these problems are more pervasive, and then how can you use that data to target your interventions.
Thank you so much. Well, you know that, as you said, it's an ever-evolving crisis, from opioid to fentanyl to xylazine and you name it. And so it's really important that all sectors together, as you said, it cuts so many different sectors, from public health social care to say law enforcement and so many in emergency and others. But you mentioned the issue of data. So let's talk a little bit more about the data, right? I mean, so at the Academy, NAM, we have a opioid collaborative. And what we're now reaching is the point of looking at data, particularly looking at even prevention, social determinants, going upstream. But there's also many data to look at who are the high-risk groups. Where do we need to provide intervention? Can you say a word about data collection, analysis, and reporting? What are the most important issues here? And
well, Victor, this is the place of my heart. And I believe that if public health and healthcare are going to be data-driven entities, we need data to be able to drive them. I increasingly feel that public health has become anemic in its ability to respond because of the lack of healthcare data. And I think you heard about this a little bit from Carlos previously, as well as John Bloom, and the efforts that have been made. But I think much more needs to be done in that space. I see my brilliant epidemiologists within my team unable to see any of the data within the healthcare system. So where is our EPI and our EPIC systems? We have to find standardized ways to be able to share both healthcare data as well as population level health data with our public health teams and vice versa. I think we really need to be thinking not just about the data does our public health teams, the federal government need, but how do we make sure that data gets back to the local end user as well? So as you mentioned earlier, I have had the honor of being in this role for 5 years and representing all the states and territories as ASTO, but I also have the opportunity to work as an emergency medicine physician. And so from thinking about a healthcare data standpoint, I can't see when a patient may have overdosed and come into a new system. I cannot see if a patient does not want to receive opioids because they may have struggled with a history of addiction. I cannot see the medications that they may have taken outside of a separate login with the PDNP, and even that may be limited depending on what components are there. On this flip side, I, as a state health official, cannot see what our overdoses look at without separate queries or get additional information in that space. So just like I can use my credit card and I can go to the local ATM and we have standardized ways to securely transfer information about my finances so I can withdraw $20 for lunch, I need ways that my EPI team can securely withdraw information from data sources that are relevant to their workflow, that my frontline clinicians can be able to do the same and patients can be able to do the same. So they know what their data looks like and they're able to put their wants and preferences into a system to be able to share information. I think that there's efforts moving this way. I think federal work that's happening with TEFCA is an example of kind of efforts that have been trying to change this example. Really appreciate Director Cohen's work at CDC and Jen Layden and many others on simplifying many of the reporting tools. But what we see is the healthcare industry desperate to have states more unified on the required conditions and what they've sent, and public health desperate for data to be able to move cleanly and effectively across spaces. So I think until we have this space, it's very hard to move forward. And I think that this is where we need to be having really robust, honest conversations about secure, de-identified as well as identified information that is relevant to patient health, that is not disease specific, but disease agnostic, so that we can have new novel insights into what we're seeing, as well as be able to reduce redundancy and the burden of healthcare data reporting and sharing.
Well said. So Fred, help us figure out how to get there. What do we need to do what Ann's talking about?
Victor, as I looked, and the paper's got a number of, I think, which are really great recommendations about some of the data challenges and how we can do a better job of sharing data in a way that becomes useful at the local level. If I had to pick out one above the others, and I'm going to read one of them, and it says we would encourage the adoption through CDC-supported analytic tools to support community-based heat maps of OUD and SUD, the complication rates that can track overdose hospitalizations and death, naloxone use, and other key indicators, kind of those trigger events across neighborhoods and demographic groups, and including linkages to other data sources like school attendance or homelessness or EMS response rates to non-fatal overdoses to inform these heat maps. And I think we can, Carlos talked about getting there already at the local level. We saw a number of examples during the pandemic. At Parkland, we worked with our local public health agency and identified, using tools that identify baseline risk, social needs index that use static data like income and employment and education to identify increased baseline risk, and then enhancing that with dynamic information that included things like comorbidities and new COVID cases and mobility data, like a number of places did using cell phone data, to then develop a vulnerability index that's useful in real time to better target individuals and neighborhoods for outreach, for education, for interventions like testing and vaccines. We found, higher rates of COVID positivity among those groups that we could proactively identify using that vulnerability index. And so the ability to share those data in real time to allow systems, health system, public health systems to better target our interventions. At the block level, we can do this, identifying schools, apartment complexes, homeless encampments, for instance, as ways to target for education on the presence of things like fentanyl, the dangers, and then to be able to, to bring in Narcan distribution and other interventions for those areas that, as opposed to sort of trying to target the entire community, we can be much more focused with our efforts with those tools.
Yeah, I think this is so right. We just need to make it happen. That leads me to think about what incentives can we provide to make these things happen? And more importantly, what kind of payment reforms can you think about, particularly to drive progress in these areas? Maybe I'll go back to Anne and we'll just go to tandem. So Anne, some thoughts?
Sounds good. Yeah, I mean, show me your priorities and I'll show you what you pay for. And that is, I think, how we get change is by changing how we change payment. A couple different things. One, about data. We saw in the move for EMRs for healthcare, public health was not a part of that conversation. So we did not invest in the public health infrastructure. I oftentimes say, working as a state health official, a role during COVID felt a little bit like everyone turned on the data flows. It felt like baseballs being thrown at us, but we didn't have the catchers meant to catch them. We did not have the data systems to catch the data that was being sent our way without destroying our systems, and had to turn many off and go back to manual reporting until we bit those up. So we think we need to think about both the sending and catching and how we pay for those data systems. I'm very grateful for the data modernization and the infrastructure money that has come through, as well as to the Center for Forecasting and Analytics. Again, I think we need to look at other models such as weather reporting and economic forecasting and the ways that key data elements are funded on a national level to move forward. We don't have key data elements that we nationally fund to say this is important for us that we all move forward. But we do this for weather, we do this for economic forecasting, we do this for other models, but we don't do that for health. And health is almost 20% of our GDP, and I would argue a big component of it. I think for payment structures too, thinking about incentives to make sure that we are paying for health and we're paying for wellness. So everything from making sure that behavioral health and physical health are integrated in as many ways as possible. It's very exciting to see the health-related social needs waivers moving forward. And you, Victor, you'd mentioned your opening comments about Director Cohen and her work previously on helping to get that started. And we're seeing a lot of states looking and moving that direction. But how can we do other things too, such as, naloxone prescribing for anyone who's on opioids? So I see a comment in the chat box about someone who's 78 and concerned about overprescribing for that age group, and it's not uncommon for me in the emergency department to see someone unresponsive and they're elderly, they've been on chronic opioids, and then they get a urinary tract infection. And so they stop breathing or decrease their mental status secondary to the combination of both. But no one in the family has been educated on naloxone or has it available to help grandma before bringing them into the emergency department and to help provide responsiveness. So I think we need to stop separating out naloxone as some sort of other than or something for people who are using heroin. It is a medication that reverses opioids, and many people are on opioids for many reasons, and building that protection within the healthcare system as a whole. And then the last thing I would say from a payment perspective is there's a lot of great work happening with public health to improve population health. And cheaper people are healthier people. So when we have healthy people, it's cheaper for the health system. So I would love to see ways that we incentivize public health interventions through the ways that insurance, be it Medicaid, Medicare, private insurance, pay for it. So for example, in the state of Alaska, we launched a program called Fresh Start. It's free, available to every Alaskan on the top driving causes of chronic diseases to make sure that diabetes, smoking cessation, obesity are all able to be addressed. And that is helping to save insurance companies money. But I think that there's a financial way to make that happen, to make that financially sustainable so that that benefits insurance companies. So instead of just thinking about congressional boom and bust funding for public health, we need to think about consistent funding for population health, which is public health. Public health can be that chief strategist and how you look across populations, and then using grant funding, using things like the opioid settlement fund to try new and innovative things to move forward, but that key amount of work is happening forward. The last thing I would say in that payment structure is, it's great to have John Blum on here previously, but I oftentimes think of public health and healthcare as this wound that has really grown within our system, and we only tie it together in really artificial ways. And I think EMTALA is one example of how we've tied public health and healthcare together. You can't bill for Medicaid, Medicare if you don't stabilize and treat a patient. But what are key data elements and what are key public health interventions that we want to insist on everyone participating in as part of a conditions for Medicaid and Medicare? It's not a popular conversation, but I think if we're going to braid those together, we need to not only think about the incentives to do it, but we also need to think about the conditions to be able to do it moving forward.
Right. So clearly we should think about use of Medicaid performance measures to align payment incentive to promote, for example, medical assisted therapy, evidence-based care models, and incentives for hospitals and clinics to distribute naloxone, as you said. So Fred, let me just move on to community health collaborations, effective and accountable community care health collaborations, particularly when you think about opportunities from SAMHSA, CDC, HRSA, community health needs assessment. Say a few words about those areas.
Sure. All nonprofit health systems are required to conduct community health needs assessment every 3 years and then develop an implementation plan to address the findings that we see. Public health agencies have a similar requirement for their accreditation. Typically, those things happen separately. And so one simple first step, pretty basic, is for the delivery systems and the public health agencies to do that community health needs assessment together as a way to start collaborating. We've done that with our local county health department for the past 2 cycles, and then working further, develop a common implementation plan, as well as even going further to start integrating data systems to gain more insights into risks and trends and conditions that you can address across that continuum in the community. So, I can think of a number of examples, promising interventions that I've seen working across agencies. For instance, the initiation of medication-assisted therapy in the emergency department or prior to hospital discharge with warm handoffs for follow-up through a community behavioral health authority provider. That crosses multiple entities. Or the integration of substance use disorder program in prenatal clinics that then depends on extending Medicaid beyond 60 days postpartum so that you can continue people that you would start on care for that important period beyond delivery. One of the things that we've worked on with our local jail is the initiation of MAT prior to jail release. We know people who are incarcerated have a higher incidence of overdose. And so working with the local jail to start people on MAT prior to release and then transitioning them into an outpatient program. But those things, involve coordinating across agencies. How do you get Department of Corrections to make this a priority? Healthcare is not what they do. How do you get, you're seeing states now explore the use of Medicaid prior to jail release to maintain clinical improvements that they've gained while working with people while they're in jail. And a key factor there is the availability of community providers to accept these individuals into their practices without prolonged delays after release from jail, so you don't lose those gains. And so you can see multiple agencies that need to work together. And I think, the easier we can make that to blend those funding streams, say from SAMHSA and Medicaid, opioid settlement funds, for example, and make those available to states and local governments is in ways that are easy to identify and navigate. I think, again, so many of those examples are happening today. And so making local entities aware of that, how to tap into that, how to access that using lessons learned will is an important way to then try to start scaling those local initiatives to more national.
Yeah. Boy, do we ever need your leadership and Ann's to actually start addressing these issues. The opioid settlement fund is $3 billion. It's going to every single state. And how you can be able to guide them to use it appropriately for exactly the kind of reasons you're talking about. Maybe Ann?
Yeah, it's a great opportunity. It's a great challenge. And I think we're very focused on what can be long-term and sustainable solutions with these funds. We don't want to use these funds in a short-term way that come in and are gone in a short period of time. So we've talked a little bit about data, thinking a lot about our data infrastructure and how to support communities to be able to have data-driven solutions. So just as Fred mentioned, how does a hospital's community needs assessment work with the local public health? Where is the opioid intervention there, and how do we move forward? How do we not just spend all the money on naloxone, but again, thinking about how do emergency departments have naloxone? How do we think about grant funding with our behavioral health team to increase MAT providers in the community, and new waivers that we've seen come through from CMS for incarcerated individuals to allow case coordination 60, 90 days prior to discharge to be able to coordinate. So using some of the funds to be able to connect that direction.
Yeah.
I think the other thing that we're really excited by these funds, because they are more flexible, is it just provides us the opportunity. In AI, we talk a lot about having, a human in the center. But I think in policy, we need to keep talking about the patient in the center or the community in the center, and building in regular ways to listen loudly with our stakeholders, to build their voices into the work that we're doing. And so a lot of our initial opioid settlement funds that we're looking at getting out are quite flexible in communities, because where they have seen gaps and needs aren't things that have met previous grant opportunities or structural opportunities within, for example, previous HRSA or SAMHSA grants. So we just did a youth mental health listening session, and something we heard very loudly from many of our tribal communities was isolation and loneliness and the importance of cultural relevancy, and saying, I want elders to teach me how to berry pick and how to fish, and I feel connected to my community when that happens. And so what ways can we help fund a small elder youth working group that really addresses cultural barriers, cultural assets and resources to be able to think about whole person health, what makes someone healthy and well, and how can that be used to address the opioid crisis as well as other avenues. I think that we have an exciting opportunity with these opioid settlement funds to try new and different things across the states. Something that we saw consistently during COVID was people tried new things, but we didn't always learn from each other. And so how can we see new and innovative ways that this is working or not working across our country? And how can we rapidly learn from each other and then build that in to ongoing systems change and take those lessons learned? That's the beauty of this country. We are so diverse. We are so different. Our local authority, state authority is so great compared to federal. We've got the opportunity to innovate, but that only goes so well if we learn from it and we make changes. We keep those learnings moving forward.
Absolutely. Certainly we at the NAM believe in learning health system. We coin that term, very much so. So time is running short. I just want to ask a question quickly to Fred, and then maybe to both of you. Fred, if you look at our action step, the last one is to help trusted community partners to provide timely and accurate information and guidance to public. How do you do that? And we talk a lot about information, but how do you make sure that we help our trusted community partners? And of course, feed the information back to the local and state leaders.
Sure. So, many of the community-based, the smaller community-based organizations, they lack the capacity to respond to some of these big, or be the lead agency in some of these large RFPs or multi-organizational programs. Yet we know that those agencies have a presence in the communities, a history of trust in the communities. They're well positioned to deliver these important messages and interventions, especially now when there's so much misinformation and heightened mistrust. And we saw a lot of examples of that during the pandemic as well, where we went to these local community-based organizations to help us deliver those messages and interventions. And so I think, highlighting the work of groups that are out there doing this work today. I know CDC puts out strong messages, places like the Public Good Project and KFF that now focuses a lot on misinformation and to identify timely messages, accurate information, messages that can combat misinformation. And then working the local public health agencies and delivery systems, working with those community-based organizations to get that information out through them as trusted messengers. You know, the data tells us that the messengers from within the communities are oftentimes the most trusted messengers out there. And so I think that's, you know, that's a central way we can do this. And we can encourage those types of partnerships when we look at grant funding, whether it's coming down from federal grant funding, opioid settlement funds, in incorporating requirements or expectations that we include those traditional community-based organizations into these models that are seeking funds to push information out to the community. So I think just
Right.
you know, having that expectation as we partner with or as we look to spend those settlement funds and other interventions that come from the bigger, you know, public agencies.
Yeah. There's a lot of lessons learned in terms of being able to inform different states and local entities how to use the settlement fund. I think there's a need to have some overarching advice and principles for everybody to learn. Let me finish by asking you just one sentence. You know, we're looking at short-term action. What do you recommend is a viable short-term step to address this issue? Now, you're going to tell me all the things you talked about earlier, but just tell me one thing you can do. And one thing.
One thing, just one. To me, it's data. That we have
Great.
streamlined data sources between healthcare and public health on this topic.
Terrific. Fred?
Yeah, it's hard to argue with that. As a delivery system, I think some of these flexible payment systems that would invest in systems of care as opposed to kind of pieces of care, systems that cross the entire continuum and invest in models that have been proven to work. Let's say looking at, you know, 11, 15 demos that have good information that's out there, and in getting that down to the local level to work across agencies.
Okay, well, thank you, both of you. What a wonderful conversation. I can go on for a long time with you, but Mark is looking at me, and he's got the tough job of managing. Mark, I started late, so I'm actually right on time. Now you got the job to figure this shit out.
No, it's a great discussion. Thank you, Victor, and a special thanks to Ann and Fred for all of their work on these recommendations and the further activities of this collaborative. I want to turn now to our final panel, which is going to step back, as we've already done to some extent, from the specific areas of opportunity in the short term around respiratory infections and opioid use disorder to the more fundamental opportunities here to improve population health and reduce burdens on healthcare systems and support and inform communities all at the same time through steps like building on the infrastructure that we have in place but haven't fully used to support healthcare, public health, and communities working together to be informed about these risks, to turn the lab tests and the admissions and the data that we're getting within healthcare organizations into knowledge that can help improve care in communities, to change the way that we're paying in healthcare with stronger primary care, better ability to reach people where they are in communities using new technologies, telehealth, et cetera, to build in an intentional focus on supporting reducing those population health burdens and supporting community efforts and those trusted voices in communities that can be part of these initiatives. So our next set of speakers includes Charlene Wong, who is Senior Advisor to the Director for Health Strategy at the CDC, Megan Rainey, who is Dean of the Yale School of Public Health, Bashara Shoker, who is Senior Vice President and Chief Health Officer at Kaiser Permanente and involved in a complementary national collaborative effort that Bashara, I hope you'll mention as well, and Rhonda Meadows, an independent healthcare expert, advisor former president of population health management at Providence Health System. And prior to that, Rhonda and I go way back to her days in leading Medicaid innovation in a state Medicaid program. So I'd like to start by getting each of your concise thoughts based on what you've heard so far, what you know is in the recommendations that you helped develop or help advise us on. What would you like to highlight as a cross-cutting theme, important opportunity coming out of these efforts? And Charlene, let me start with you, as I know you've been involved in a lot of the activities at the CDC, work with the other federal agencies on helping to advance some of the recommendations that we've talked about here today.
Thanks so much, Mark. And let me just say again, on behalf of Mandy and myself, we really appreciate so much the work of this group and it's been great to work with you all. Mark, what I'll highlight is, as we continue to work to protect health as a team sport, as Mandy said at the top of this webinar today, we're quite focused on a couple components of what is really needed. I think one that has come up so many times today is that data integration piece. And another is thinking about those roles and responsibilities and how we in public health, if we're going to stick with the sports metaphor, continue to pass the ball back and forth. And I just wanted to tell one quick story because I feel like we've talked about a lot of different pieces of the recommendations, but one story that happened recently that sort of pulled all of this together and that happened here in the US, and that's our US Mpox response. And the story here that perhaps people may not have heard at this point is that the way that public health, healthcare, the public sector, private sector were able to come together really quickly, do some of that data integration work and work to pass the ball back and forth. In this case, the ball was testing for Mpox, because we actually at the outbreak of Mpox had a test that we had in public health. The challenge is we did not have the capacity in public health to do as much testing as was needed as quickly as it was needed. And so CDC worked with FDA and commercial labs to both pass that test over to our commercial lab partners who were able to scale up how quickly they were able to manufacture the test, and then importantly, also get that into the hands of healthcare providers. I feel like Anne and others have referenced this already, right? It's got to be things that are built into our system so that, say, if I was seeing a patient in clinic, I could order an Mpox test the way I would any other test. And then that data integration piece came into play when the results came back from those tests. They were sent via electronic case report back to electronic lab reporting, back to public health. And, results to go from 6,000 to 80,000 tests done per week. And at the same time, all that was getting scaled up, we started seeing cases decline. So I just want to, again, emphasize that this is definitely possible. And those are a couple of the key pieces: data integration and clear roles and responsibilities to highlight. Thanks.
Thanks very much, Charlie. And maybe come back to some of those issues. And that really was a good example. There were some challenges at the beginning of COVID with respect to testing, but that model of a public health agency role, CDC, FDA, making available a reliable test that can be used at the very large scale availability of testing between commercial labs, hospitals, et cetera, in our healthcare system, and getting that data shared anonymously at the local level to inform public and private responses together. Great description of how these roles can fit together in line with our recommendations. Megan, could I turn to you next?
Sure. Thank you, Mark, Victor, and the CDC for bringing us together today. It's a true joy to have this report out and to be having this webinar. So in terms of the things that stand out to me the most, I'm going to say it's really about both soliciting and collating that data from a variety of different sources, including healthcare, but also including the community, and then the commitment to sharing it back out. I'll say, as both a healthcare provider and obviously now a dean of a school of public health, healthcare is in some ways at the center, but if we center our health responses on healthcare, we're making a big mistake, both because our healthcare system is already, as Anne and others have talked about, totally overwhelmed already, and because healthcare is not set up to fix or address many of these core public health issues that our communities are facing. So a couple of examples where that kind of bidirectional data informs solutions, but then data is also shared back through great communication with communities. One is around our response to our really kind of ground up response to the PPE crisis in the beginning of the COVID pandemic. As many of you know, I helped create a nonprofit called Get Us PPE that was created as a coalition initially of healthcare providers, then included the private sector, many companies that were interested in changing to manufacturing of PPE, as well as with state and local health systems, and of course with public health professionals, computer scientists, business professionals, et cetera. At that point, there was no national data on PPE shortages. We served to bring in data to serve as a place for people to tell us where and why they were facing PPE shortages, and for us to then use data to share back out both donations of PPE, but also communication about where our country was facing shortages. We used that as a way to elevate the importance of high quality masking, especially early on in the pandemic when we had nothing else to prevent transmission, but allowed us to again, close that cycle that Anne was talking about. Another example of how we can both use data and communication in sync is around a lot of the work that we do on violence prevention here in Connecticut, from the state that I was most recently in, Rhode Island, as well as in other locales across the country. Really, the core of violence prevention is identifying where we're seeing clusters or hotspots of real outbreaks of homicide, suicide, domestic violence, and so on, helping to identify folks that are at highest risk and then delivering interventions appropriately. We as healthcare providers see the end result when violence prevention isn't implemented appropriately, right? We're the ones to take care of folks who have been assaulted or who have tried to take their own life. But there's a host of ways that we can prevent it upstream. When we have good data on where to invest and address limited resources, we can often interrupt that cycle of violence. And we can communicate with communities who are experiencing violence to decrease fear, to decrease after effects, and to help increase community support so that we kind of, again, decrease the incidence, decrease the burden on the healthcare system, and end up in a virtuous cycle back for health. Core to all of this is it making sure that the community understands how to use that data and is empowered to share their interpretation of the data and their interpretation of best practice in a way that makes most sense to them. I think Charlene's example around MPOX and the work that Dimitri Daskalakis did as part of the MPOX task force is just so amazing and impressive in terms of that elevation of community messengers as trusted communicators in parallel to the delivery of evidence-based interventions.
Great. Thanks very much, Megan. Really appreciate those concrete examples of how these different organizations can work together. That's what we're trying to build on in this report, show some areas for action, and then go through the concrete ways in which progress is possible now for more effective collaborative action supported by the federal policy reforms that we recommended. Bashara, you were next on my list, and I know you've had a lot of opportunities to think about these issues as part of the Common Health Coalition that you're helping to lead too. So maybe you could work that into your response to this leading question.
Yeah, so thank you, Mark and Victor and everybody else on the panel for inviting me here. I've been incredibly excited about the progress that we've made together in this collaborative over the last many months. And I think what I like the most about the work and what caught my eye the most about this work is how practical, pragmatic, no regret actions that can be taken to actually make a difference. And this aligns totally with the work that the Common Health Coalition has been doing, and we've been working very closely to make sure that the work here is complementary in the space. Just a little bit about the Common Health Coalition. About a year and a half ago or so, the leading health healthcare associations, organizations came together with Kaiser Permanente to create this Common Health Coalition. It was the American Medical Association, the American Hospital Association, AHIP, which is the association that represents the insurance companies, as well as the Alliance of Community Health Plans. They all came together with Kaiser Permanente to try to figure out where do we need to focus as a healthcare industry on key priorities and take no regret actions that we need to put in place to really strengthen the interface between public health and healthcare. And over the last year, we've identified 4 areas very much aligned with the actions that this collaborative is putting out. We've identified priority areas to create more concrete coordination between public health and healthcare. How does that look like? How do we bring it to life? How do we execute on that? So that was one area. How do we plan for emergencies together so that when there is an emergency, we're already have planned for that and we're ready to go. So we're not taking time to plan for emergency when the emergency happens. So that was another area that we spent a lot of time and energy on. The third area is a topic that we've covered extensively in the panel and the discussion earlier today, which is around data and data integration and data flow between public health and healthcare. And then the fourth area that this coalition is focused on is around what needs to happen to make disease detection easier, faster, and that's an area that we spent a lot of time and energy on. So over the last year, these 4 organizations, together with Kaiser Permanente, through a facilitated process, we've identified key no-regret action that we will be announcing publicly in the next couple of weeks. I think March 13 is the date that we're going to be making those commitments, very specific commitments from each one of these organizations. AHIP, AMA, AHA, ACHP, and Kaiser Permanente will be making them public so that we can really track and measure the progress we're making on furthering that interface between public health and healthcare. And David Chakshi, who's the chair of the coalition, will be making those announcements at a political event public on March 13. So we're really excited about that.
Great. Thanks, Bashar. And sounds like very complementary to the policy reform steps discussed here and the shared action opportunities. Rhonda, let me turn to you. I know you have some very important perspectives. Up until recently, population health was in your job name. And it's been an important part of your career in bringing this population health focus to healthcare. So your thoughts about the work to date?
So I think that I cannot be more excited about what this team has pulled together, the collaborative pulling it together. It seems like we finally are going to put our good efforts into an effort that actually needs to address what always happens whenever we get into an emergency. We get into an emergency, tragedies occur, everything happens, and we realize what we don't have. But what this thing did, what COVID 2019 did, was actually make us all lean in. And for Providence, I think, we started it where the COVID started in Washington State. We had to move fast. We covered the 7 states, but what we found was that when we looked amongst ourselves, we actually had public health trained experts. We actually had epidemiologists. We had people who could work with local public health departments who were, while doing their best, were still under-resourced. We created not only our ability to have advanced analytics to predict and plan what was happening with COVID-19, but we took it also out and used it with our population health management systems. So all the things that we've been talking about adding in, not only the public health information itself, but also the healthcare data, the health plan data, the community health information, all that stuff, the pharmacy data, all those things needed to come together and actually help us to be able to plan at a community level how we're going to address and how we're going to proactively try to prevent some of the harm. We've since taken those same systems and added in not only the risk assessment of all of our patient populations, health plan members, but also the members of public in general. But we also added in the piece where you can actually try to figure out who is at risk for future harm and going forward with it. We use these information, we use a data system, we use the process we came up with to actually inform value-based care. So talking about putting your money where your mouth is, it actually means taking that information now and using it to identify where we need to be focusing in. It's not enough to say that we're improving clinical quality. We actually know that there are populations within the general population that need additional focus, additional efforts and interventions. This is a way for us to use public health information, healthcare, health plan, community health data to actually inform our actions, to predict where the problems are going to be, to actually inform the strategy to intervene and then track our progress. We use the information for value-based care as well as health equity. So I'm thrilled. You cannot possibly know. I won't do the happy dance on camera for you, but I am thrilled that we're able to see this work move forward. I'm really excited that we've chosen respiratory illnesses and overdose as 2 areas of initial focus. So fantastic work, guys.
Great
I'm
job.
just a little excited.
Thanks so much, Ron. I actually wish I could see that happy dance. Unfortunately, I think we've lost your video feed, but we heard you
Heard me?
loud and clear
It
on the.
was fabulous. It included jazz hands.
Well, if I could ask just one quick follow-up for you
Back
on
on.
there you are again.
Yeah.
Good to see you. Sorry you missed the dance, but you mentioned the work at Providence on population health and building all these systems in. And getting back to roles and responsibilities here, it does seem like the ideas that John Blum and others discussed, and there are recommendations about payment reforms in healthcare to strengthen primary care, to provide more resources that can be devoted not just to those hospitalizations and downstream complications like Carlos was talking about earlier, but detecting the problems earlier, integrating your data with data from the community, engaging the community. That seems like a critical part of making this happen, but it needs to be paired with that information support from public health programs, right?
It absolutely does. And I think we were doing it, but we didn't call it what it was, right? We would take the information from public health about what was going on in our local communities. And while we tend to think about as a healthcare provider, who is our patient, and we think as a health plan, who are our members, they are all in the same community. It still overlaps. We were using the information, but not calling it what it was and understanding the value of it. When COVID-19 happened, it actually became crystal clear. We went beyond tracking and trying to predict what was happening with COVID-19 and went to all the other things that we know are problems in our communities. Heart disease, asthma, mental health crisis, all those things came to shine. So absolutely.
Yeah, so very much in line with the recommendations here. And I do want to thank our audience for sticking with us for this very important set of discussions on these new recommendations. And I was going to try to get in a few of the questions, comments that have come up right now for the group. Several of them are related to how we could do potentially even more with intentional steps to put together individually privacy protected data to get more situational awareness from healthcare, including these additional laboratory testing and other capabilities with non-healthcare data, community, other types of community risk data. AI, one of the questions was, can potentially help with that. Other types of non-health data that could potentially be integrated. And then also several questions, essentially picking up on Rhonda and many of your last points about just how important it is to listen to communities and get their perspectives and build on the trust and knowledge that they have about reaching people who are at risk in ways that traditional healthcare hasn't done. Now, the new roles that we've talked about in these recommendations or evolving roles, I should say, for healthcare, for public health, and community organizations working together should help with that. But I'd appreciate, and we are running short on time, if each of you might, in a final comment here, add anything that you'd like to add about some of these topics that have been brought up by our participants today, and any final comments you'd like to make. And maybe, again, I'll go in the same order that we started with. Charlene, if you don't mind starting with you.
Yeah, well, again, Rhonda, I will do some jazz hands with you over here. We are extremely excited at CDC about this work and really continuing to take the words that are in this issue brief and bring them to life in more of these collaborative actions. Mark, maybe for my final comment, I'll build off of what you were just saying, which is that the importance of building those relationships and that trust just cannot be overstated. And that takes investment and time to do that. And so I think one call to action that could be used as a starting point for any of the recommendations from this issue brief is just to start with outreach. If you are someone who is in healthcare, reach out to someone in public health at your state or your local level and vice versa, right? And get to meet each other And in the ideal world, identify some of the top health threats that are facing your community now, the way that we in this group identified respiratory illnesses and OUD. Perhaps those might be the ones that you choose as well, but perhaps there's something else. Megan, you mentioned firearm violence, for example. And so I think in my closing comment, it would be, we should all get started now. And again, that could just start with something as simple as an outreach to meet some of those partners that perhaps you haven't met before or haven't connected with in a while. Thank you again so much.
Great. Thanks very much. Megan, back to you.
Gosh, Charlene took the words out of my mouth. So, but so to add on to what she said, I think there's also that element of kind of respect between the two systems, having sat in both of them, both of course during COVID, but also over the last 20 years, right? The ability to listen to each other and work together between public health and healthcare systems to understand the perspectives of doctors and nurses and physical therapists, but also to understand the workforce challenges of the folks that are doing the day-to-day work of public health, that are collecting that data, presenting the epidemiological analyses. So not just reaching out for partnerships, also having that respect for what each of us bring to the table, I think is essential. The additional thing that I'll add is kind of from the workforce perspective, thinking about how we can bring the next generation in to help with this work. Whether it is, and there I will put in a plug for academic medical centers and academic schools of public health as great partners with both state, county, territorial, city health agencies, and great partners with health systems and community groups that our students are enthusiastic, come from the communities that are affected, and are often quite eager to do this work and to bridge these gaps, but are just looking for places that they can start to get their feet on the ground.
Yeah, thanks, Megan. I really appreciate your bringing up the point about workforce. Carlos and I, in our discussion earlier, kind of alluded to that kind of traditional medical training, traditional public health training, the walls need to break down there too, as we think about a more efficient and effective healthcare workforce that brings in more people from diverse communities as part of care teams, again, made possible by the kinds of recommendations we've had here. And similarly on the public health side, the resources are limited, but there is a lot of potential help and synergy through the kinds of recommendations we've made. Bashara?
Sorry, Mark, if I can just add on real quick
Please
to
go
that.
ahead. I know it's
No,
I know
it's
it's
okay,
a topic
I'll be
you
super
love.
quick. But to add on to that is also that partnership with private industry as well.
Yes.
Right, as an additional place of training and support, and then scaling of the work that we all do. So when you're thinking about workforce, to not think of it also just in terms of public health and medicine, but also there's a much larger workforce out there that is all bought in and has a role to play. So.
And especially with better shared data ability as a result to do more informed community needs assessment, as Fred talked about, and then hold each other accountable for progress for the resources that are going in. Boy, it sounds like a good path forward. Bashara?
Well, I'll just highlight two key points. One, and they're both related to the third action from this collaborative. One, I think figuring out how to strengthen the connection between community-based organizations and public health is so critical. I served as White House vaccine coordinator in 2021, and I've interfaced with literally hundreds of CBOs that are trying to do the best they can to get the vaccination rates up in this country. And so over the last year or so, we've worked with the CDC Foundation, and we've interviewed over 100 experts. We've looked at tons and tons of best practices from the interface between public health and CBOs during the pandemic. And the CDC Foundation is putting out a set of recommendations that will be made public, I think, on March 26th or so. So I would encourage the audience to track that, look at these recommendations, and really take these recommendations and put them into action around key domains like leadership, issues around data interface, issues around community engagement. So some key concrete recommendations, and the role of the CBOs, I can't underestimate I can't emphasize enough how critical it is for this work. And then the second thing I want to highlight is something you and Carlos, Mark, touched on during the conversations, and Carlos brought up the importance of the incentive and the importance of paying for value when it comes to healthcare. Look, I work for Kaiser Permanente. We are, by design in our DNA, we're a value-based system. That's how we were created. And as we see more and more transition of healthcare systems moving into value, with the launch of Rising Health that we've done and identifying health systems across the country that are interested in that move and supporting them in that move, that would be a huge add into the further alignments between public health and healthcare. So I want to stress the importance. It was great to see John on this webinar earlier today. The role of CMS can play, the role that we can help move systems into value-based care is going to be another huge added value to the interface between public health and healthcare.
Thanks, Bashar, and we do really appreciate the CMS involvement from the senior leadership on through the agency and in these efforts with us and in their collaborations with CDC and the other public health agencies to advance the kinds of goals we've talked about today. Rhonda, I guess I'm not going to get to see the dance, but I do want to give you the last word from this panel. There we go.
Last words are action must follow promising words. H1N1 pandemic was 2009. COVID was 2019. We do not need to wait another 10 years to move and act. We've got people waiting for us to do better in terms of what is served by value-based care and what comes out of health equity. So if you all join me in a little bit of jazz hands, just go ahead and get it done. Get it done. Thank you. Show the excitement because that's how you move from words to action.
All right, that is a great action to start with. More to come as a result of this paper. And just again, hopefully you all who have joined us today have been able to get the issue brief, and the more detailed paper will be out in several weeks. We'll get that out to everyone as well. And on this note of action needing to follow words, Victor, let me turn back to you to close us out this afternoon.
All right. As you know, we're all about action. So Rhonda, action not only jazz hands, but you see my body and my legs moving. All right. So listen, thank you, Megan, Rhonda, Charlene, and Bachara. A terrific, really important discussion, bringing all these things together. So, boy, what a great almost 90 minutes we had today. You know, it's one of the very best. And I'm so grateful to all of you, the discussants who are very busy. I know that because I know many of you who's actually not only take time to speak with us today, but many of you work with us in this planning and this issue brief and recommendations. You know, so when Charlene, pardon me, when Mandy first took the job, she called me to say, let's do something together. How can NAM help me to achieve the goals that we need for our nation? And then she also spoke to Mark. That's when Mark and I spoke and said, how about we all join forces? And sure enough, I think you see one of the early products of our partnership together. Very exciting. And Bachara, your coalition is very exciting. So we immediately invited you to join as well, because to me, it's really a continuum of what we're trying to do. So thank you very much for all of you. So I think the question is, what's ahead? Well, first of all, we do have the issue brief, and one of the participants asked that he got a blank sheet. I'm sure that's fixed. But it is already up on the website, and we'll be sharing a link to that paper recording from this webinar. So you'll be able to see that. I'm sure we can do it very soon. Secondly, as you heard from Mark, we are in the midst of review and soon publishing a full-length paper in the National Academy of Medicine Perspectives. So you'll be able to read in detail the deliberation recommendations of this entire group. But as Rhonda said, we're not going to stop there. It's about action. So while we have some very short-term ideas, of course, we're going to see it implemented through many of you, our federal collaborators, our private sector, you name it. But we want to see this issue as a long-term issue. That is our collaboration, certainly with Mark McClellan, CDC, CMS, and all of you, is long-term to look at how do we actually achieve the health vision for our nation. Collaboration between public health, healthcare, and social services. So our intention is to build on these topics to continue to work on them in the long run. So please stay tuned, because this is not just the 18 months, this is a long haul, and I want many of you being involved with us to pull together the many visions already put forward on public health, but then to take it further in a more practical fashion. How can we achieve the health for our nation? So thank you, Mark. Thank you, Charlene. Thank you, Mandy. Thank you, Fred. Thank all of you. And please sign up for more information on these efforts via NAM Duke-Margolis website and newsletters. And please keep an eye out for updates months ahead. Now, we all realize that there's an election coming up. And of course, one can never predict what happens. But I think the work done by this group as neutral, independent, evidence-based is going to carry the day, irrespective of what administration is in. So you can be assured that we're going to continue working on this issue going forward. So thank you again. And Mark, do you want to say any last words?
No, just my thanks to everyone who's been engaged in this effort. That goes for our participants in our planning group you heard from today. It goes for our federal government partners and advising and providing some very useful guidance and enthusiasm for these efforts. It also goes for our staff at Duke-Margolis and the National Academy of Medicine that did all the work to pull people together and help us sound coherent. And finally, it goes for all of you who are with us here today. This is a collaborative effort that it's not something that individual healthcare organizations can solve, not something that public health stretched organizations can solve. Finding this common ground and these practical ways forward are really something that I hope we can all keep working on together. So thank you all very much for joining us today, and we look forward to action.
All right, thank you, Rhonda. You see me doing this? Thank you.